Hi, everyone. Thanks for joining us today. My name is Dr. Brooke Messer, and I'm joined by my colleagues, Drs. Mitch Eibach and Travis Witt, and we're from Vance Thompson Vision. Mitch, I'm going to have you keep going with epithelium on cross-linking. We participated in the trial. I know you guys did. Travis, did you guys do epithelium on corneal cross-linking in Bozeman in the trial?
Yep, we did as well.
Okay, so all three of us have that, and being so it's still kind of investigational, we can't comment a lot, but I do think it's a great part of the future of keratoconus management. What are you guys looking forward to with epithelium on cross-linking being available to our patients in the future?
I'll start. I think it provides for sure a shorter procedure. Currently the Dresden protocol, what we do now with epithelium off just takes a long time. It's over 60 minutes for patients. It's 30 minutes of drops, 30 minutes of ultraviolet light with more drops. And so it takes a lot of time for patients. With this, hopefully we have a shorter procedure. And then second is the epithelium can stay intact. Now, I don't want to mislead people because I bet your guys' experience is similar to mine. Some of these patients will still have an epithelial defect because you have to kind of try to loosen the tight junctions of the epithelium to get riboflavin dispersed through, and there's maybe a drying effect during the procedure. And so some of these patients still come back in. It is not the next day everyone's feeling perfect, and some of them still do have an epithelial defect, but better patient comfort is the second thing.
Yeah, I think it'll be interesting to see, how the epithelium remodels post cross-linking when it stays on the eye, if it needs to remodel at all. Travis, I think Mitch took all the good ones, but do you have anything to add?
Yeah, I mean, I would echo what Mitch says. I think for what we saw in the study, epithelium definitely looked a little more rough that first day or so. So, it wasn't perfectly intact. It didn't look like an untouched cornea. And so we still tell patients, you're still going to have, the potential for some blurred vision. You definitely could still have some irritation for a day or two, but it's, I think one of the big benefits is, vision returning to normal when you remove the entire epithelium and go through that whole remodeling process. Typically have a higher potential for post-op corneal haze, which not every patient goes through, but treating 3 to 6 months of haze is, there's a lot of hand holding in that with patients. I think there's a potential that you have less component of that, given that we're not removing epithelium, more so just kind of roughing it up a little bit.
Yeah, I agree. I agree with both of you. Some other future keratoconus management options, and these are more along the lines of vision rehabilitation to help us improve the patient's opportunity to get into maybe glasses and soft contact lenses rather being committed to a scleral or a corneal gas perm. And I'll maybe jump into this a little bit, and then you guys can both add anything that you would like. The first one is called corneal tissue addition keratoplasty. So you might see some of these patients, depending on where you're listening from, you might be seeing, there are surgeons across the country doing this right now, so you might see a patient or two. And these are going to be patients that are maybe on the thinner side, moderate to advanced keratoconus. And it's actually similar in thought to Intacs. The problem with Intacs was that it wasn't very corneal compatible, and it created a lot of inflammation and neovascularization. And that it wasn't very customizable, where CTAC actually has a customized donor tissue. So it's a piece of a donor cornea that's been irradiated. So it's no longer living tissue. So it cannot reject. But it can be customized in the size, the thickness, the placement, all of that. So it's a much more customized treatment. The patient's individual pentacam images are analyzed, and then the surgeon gets this big report about where to place the tissue, how thick to make the laser channels and all of that. So it's just a very customized treatment with, again, the goal to improve the corneal surface for refractability. So again, these patients aren't looking for vision correction freedom. It's more just allowing them to have more options with better vision quality. And then second is topography guided PRK. For these are more of those mild moderate cases where there's maybe a little bit of tissue to give. We definitely don't want to go below that. We don't want to make the cornea too thin, but it's just kind of removing some tissue or, shifting the tissue in that it again allows for just more refractability, decreasing irregular astigmatism so that patients can again get into glasses and contact lenses, maybe soft toric lenses. We probably wouldn't do this on an eye that isn't stable. We want these patients to be cross-linked first so that we can feel comfortable about doing something like this with a laser. Do you guys have anything to add on these these treatments. I think it's exciting for the future of keratoconus.
Yeah, I would say definitely exciting. I think the challenge in seeing patients with even mild to moderate, but seeing patients with keratoconus when they've had visual impact, they don't correct as well. Maybe they're intolerable to contact lenses, or they're a challenge for them, where we know contact lenses have a place in this paradigm to give patients best corrected vision. But the tough part is telling patients, when they come in, we're going to do a cross-linking procedure that's aimed at stabilizing the corneal tissue. It does not improve your vision. It doesn't make you more correctable. And so you're telling these patients, like, we're just trying to stop it from getting worse. And having potential advancements like these that give the potential of reducing irregularity and kind of potentially normalizing that cornea to where these patients have a better possibility of refracting better, wearing glasses or soft contacts. Obviously very selective in who qualifies for these, but it's exciting.
Yeah, and our surgeons or Dr. Greenwood is particular about it as well. Like, we won't consider any of these things unless the patient basically proves to us that they're really struggling with their gas permeable contacts or their scleral lenses. And so the goal would try to be able to kind of simplify that into a soft lens or glasses. So again, it's not aimed at getting them out of correction. And I know you have a few patients that have had both of these things, Mitch. Anything to add to Travis's comments?
I don't think so. We're probably 15 to 20 CTAC patients in now here in Sioux Falls. We've combined this with ICL, or implantable Collamer lens. In a patient or two, we've combined this with cataract surgery in a patient or two, again, trying to just have a more normal corneal shape before going into some type of surgery. Topography guided PRK, we've done both with what's called the Athens protocol, where you do one first, then the other, back-to-back days. We've also done it where we've had a patient cross-linked first. Years down the road, we come back and try to do topography guided PRK. Again, rehabilitating the corneal, trying to normalize the anterior corneal shape to really get better vision. I think the big take home for me with both of these, Brooke, and you said it, is these are trying to get patients into glasses or soft lenses. And so the education that we give as their optometrist has to be much different. This is a situation where we want to overproduce and underpromise.
Yep, for sure. And so with that, let's talk a little bit about where contact lenses fit into the process with corneal cross-linking and keratoconus. And I'm going to kind of run with it, but you guys can certainly interrupt and add in some comments based on your experience as well. With soft lenses, basically, I recommend to patients that they can resume their soft contact lens wear after having corneal cross-linking done around 1 to 2 weeks. It's basically when you think the epithelium can handle the daily on and off removal of a soft contact lens. So maybe it depends on the age of the patient, how long they've been wearing contact lenses prior to this, any sort of dry eye findings that I'd be worried about disrupting the epithelium. But again, typically I stick to about 2 weeks. Depending on patient circumstance and experience. Scleral contact lenses, I also feel comfortable getting a current scleral lens wearer back into their scleral lenses around 2 weeks for established wearers. Again, these are patients that put the lenses in and take them out very comfortably, very confidently. New lens wearers, 1 to 3 months, depending on the severity of the cornea. What we would hate to do is start a new lens fit and then have them kind of change as they stabilize over 6 to 12 months and then ending up needing a change in their scleral lens. But, I used to stick to 3 months, where now I'm kind of shifting toward 1 month and not really having a lot of change. And so I would say now, about a 1 month start for new scleral lens wearers would be acceptable to me. Hybrid lenses and corneal gas perms, they interact with the corneal surface just a bit more. So I try and push to 1 month just to make sure I have plenty of epithelial shape change and healthy, fresh, sort of that non-fragile new epithelium, so that we can, appropriately apply and assess these lenses during the fitting process. One thing that I think is important to remember when it comes to contact lenses with patients who have keratoconus is that our contact lens technology nowadays, especially in scleral lenses, is so darn good that we can sometimes just assume the patient is doing well because they can see 20/20 in their scleral lens. They kind of forget that we kind of forget that, hey, this patient probably has reduced wearing time. They have to take their lens out earlier than maybe somebody who, has a normal cornea does. They have itchy eyes, they have irritated eyes, they have dry eyes. And so just because they seem to do well in their contacts, that we can pass the opportunity to treat with corneal cross-linking. Corneal cross-linking improves quality of life. It reduces the mental burden on patients with keratoconus. And so again, just because they're doing great in their scleral lens doesn't mean we can just go year to year to year, making those small power and contact lens adjustments to adapt to that corneal change. We don't manage any other disease like this. We don't let, cancer or high blood pressure or any other disease get a little bit worse before we actually refer for treatment. So again, just because they're doing well in contacts doesn't mean that they get a free pass on having corneal cross-linking done. In fact, there's data out there that says good best corrected visual acuity in patients with keratoconus, it actually is disproportionate to their quality of life. So patients can see really well, but they still feel like keratoconus significantly impacts their quality of life. So we can't base on how the patient's doing just on their correction in contact lenses. And even the CLEX study, somehow that got cut off on this slide here. But the CLEX study back in 2004, 10 years before we even had the opportunity to cross-link patients, they noted that clinicians who manage patients with keratoconus can be led into therapeutic complacency because the patient has good visual acuity in their contacts. And so again, just don't let yourself fall into that mindset that my patient's doing good for the 10 minutes I saw them this year. And so I'll just wait a whole nother year before I see them again. Again, the best thing to do for these patients, even if they're doing well in contacts, is to make sure to get them cross-linked. Just a couple of comments on new tech in contact lenses, particularly sclerals. We have scleral topography, which maps, out to 20 millimeters on the corneal surface and allows us to build a really customized contact lens, which is really nice. And for patients who come from a ways away, like sometimes they do in Fargo, serving some rural areas, it's nice to be able to just scan the cornea, get the image, get the lens made, and then have a lens that's nice lock and key with this type of technology. Impression-based designs are also really fun to do. I had my impression done a few years back, and thankfully this third image is not my cornea, but you can see, even down to the sutures on this transplant here, how detailed those impressions can become. And then they basically use a 3D model to create a custom scleral lens with custom depths and curvatures and all of that. Many lenses nowadays, even the diagnostic fitting set base scleral lenses, have unique landing curves to vault over things like blebs and large pinguecula cysts and things like that. So just some good stuff to think about with corneal cross-linking and patients wearing contact lenses. To close, I just have a couple comments on how, we know so much more about keratoconus than we ever have before, and that has allowed us to change the way we diagnose and treat these patients. And thankfully, it's better than it's ever been before, and that we really should recognize that cross-linking is an essential treatment. Mitch, I'm going to have you wrap us up.
Yeah, thanks, Travis, Brooke. I think this was great. Hopefully we gave our colleagues pearls, tips, things to use in their practices to better take care of patients. And if this sparked interest in you, you want something more, we'd love to invite you to have a personalized mini fellowship here in our practice, whether it's with Travis in Bozeman or Brooke in Fargo or one of myself or my colleagues here in Sioux Falls. We'd love to have you come in, see some patients, hopefully immerse yourself in a hands-on experience, talking with our optometrists and ophthalmologists so that we can really better take care of the patients that are in our communities. Remember that eye care is ever evolving and changing. And so we're all kind of at really the tip of the spear to better take care of patients. And this is just something that we offer. We'd love to have you.
Thanks, everyone.